topic is 8 changes in periodontium. Now, periodontium involves again two hard tissues, that is your cementum and your alveolar bone, and the two soft tissues, that is your gingiva and the periodontal ligament. And as you can see in the picture, now it describes the various parts of the gingiva where the periodontal ligament is present, your cementum, and everything is clearly labeled. So what we're going to talk in this topic is the 8 changes that happen in all of these periodontal tissues, that is, be it your cementum, be it your gingiva, be it your periodontal ligament, and be it your alveolar bone. Now let's see slide number 1. First, we will talk what are the 8 changes that are happening with respect to your gingiva, be it the changes in the gingival epithelium or the changes in the gingival connective tissue. When you see the gingival epithelium, the first thing that you should see what happens with age is the thinning down of the epithelium. So as the epithelium thins down, there is increased permeability. So your epithelium becomes very much permeable, and it allows anything to penetrate inside. So therefore, the mechanical integrity is reduced. So as a result of which the property of physical barrier is a little bit compromised in case of aging. Apart from the thinning of the epithelium, there's also decreased keratinization. So as the age advances, the process of keratinization decreases, as a result of which again the mechanical barrier or the physical integrity is compromised. The second here is what the changes that you notice mainly in the epithelium is the decreased retipex. Normally, what kind of an epithelium we see in gingiva is your stratified squamous keratinizing epithelium and stratified squamous non-keratinizing epithelium. So you find stratified squamous keratinizing type of epithelia in your outer or the oral epithelium, and then your sulcular and your junctional epithelium are mainly your non-keratinizing form of stratified squamous epithelia. So these retipex are a striking feature of your stratified squamous keratinizing form of epithelia. So what happens with age with this retipex is they get flattened. So as the retipex get flattened, what all can happen? The decreased surface area. So the surface area of the tissue will reduce, and then as a result of which the integrity with that of the connective tissue also can be compromised as a result of the flattening of your retipex. Apart from that, there is an altered cellular density in respect to as the age advances or as with aging. That is with your epithelium. Now what happens in your gingival connective tissue? The first thing that happens is your gingival connective tissue will become more coarse, it will become more denser because of the increased content of your collagen fibers. So your collagen fibers increase, though there can be great mechanical strength of the connective tissue because of the increased collagenous nature of the tissue as a result of aging. But what you should know here is that the soluble form of collagen, see, always any part or any tissue always remodels itself, that the old one breaks down and the new one forms, right? But what happens as a result of aging is that the soluble collagen, that is the normal collagen, as a result of aging, which is soluble for the breakdown of it by enzymes like collagenases, will become insoluble. Now as it is turning to become insoluble, it can't be broken down, and then even the denaturation of the proteins, the temperature increases. So all these are the changes that you see in connective tissue. So you have a coarser and denser connective tissue. The soluble form of collagen will become an insoluble form, and then even your denaturation temperature also increases with aging. Apart from that, there is an increased deposition of collagen with aging. That's why you see more coarser and denser form of collagenous connective tissue. Now what happens to periodontal ligament? So we finished with gingival changes. What happens to periodontal ligament? First thing what happens is there is a decrease in the cellular content of periodontal ligament. Your periodontal ligament is composed of various cellular parts. That is, it has your synthetic cells, you have your resorptive cells, you have your osteoprogenitor cells, you have your epithelial cells of Malleus, and you have your inflammatory cells. The synthetic cells include the ones which synthesize something. That is, fibroblasts which synthesize your collagen, you have your osteoblasts which can form the bone, and then you have your cementoblasts which form your cementum. When you see the resorptive cells, they are the ones which resorb. What are they? They are your cementoclasts which cause resorption of cementum, you have your osteoclasts which resorb the bone, and then you have your fibroblasts itself which resorb your or which will break down your collagen. So the beautiful thing here is your fibroblasts have a dual role. They on the signal like whatever is required at that particular time, they either break down the collagen or they form the collagen. Though there is a little difference in the morphologic characteristics of these collagen degrading fibroblasts and collagen forming fibroblasts, but the fibroblast has the role of dual role. Either it can cause formation of collagen or breakdown of collagen. So as a result of aging, what is happening? There is decrease in the cellular content of all these cells in the periodontal ligament, especially your fibroblasts. So if the fibroblasts are decreased in number, what will happen? There is decreased collagen synthesis. So as a result of which you have decreased collagen synthesis, but there is an increase in your elastic fibers. Okay, so as a result of aging, there is increased elastic fibers, decreased number of fibroblasts, and decreased organic matrix production, and even decreased epithelial cell rest. What happens to cementum? We know that cementum increases in thickness as age advances. There is deposition of cementum apically as age advances and even laterally as the age advances. Why? Because as a result of age, most common feature or the most common hard tissue finding is attrition. So because of attrition, there is a kind of a passive eruption of the tooth. Okay. Now after the tooth development, it has to erupt right into the oral cavity. That is your active eruption. But then as the age advances, because of the attrition phenomenon, your tooth, in order to compensate for the interocclusal distance, it erupts, and this will become your passive eruption. Now if the tooth has to erupt passively to maintain the occlusal height, there should be something which is to be formed in the apex of the root. Now that is the cementum, which is forming as a result of aging. Then what happens to the alveolar bone? First thing, your alveolar bone will, the alveolar bone facing the periodontal ligament will become more irregularly, the bone which forms, again alveolar bone has a property of remodeling, right? So you have resorption, you have deposition, a continuous process. But this can slow down as a result of aging because the metabolic functions of the cell itself can be reduced as a result of aging. Apart from that, your alveolar bone will become more irregular, the one which is facing towards your periodontal ligament. So the attachment with your Sharpie's fibers can be compromised. Then apart from that, you have less irregularly or less arrangement of your collagen fiber. That's what your Sharpie's fibers get less regularly arranged onto your or inserted onto your alveolar bone which is facing your PDL. What happens with the bacterial plaque? Now these are the changes what we saw with respect to your periodontium. And apart from that, there is an important finding as a result of aging. There can be changes in your composition of your bacterial plaque. First thing, there can be increased deposition of plaque. It can be because of aging reasons like dexterity in maintaining oral hygiene. Apart from that, there is an increase in your dentogingival or there can be periodontal diseases. As age advances, if the maintenance is not good, it can lead to periodontal diseases. So there can be more and more deposition of plaque, right? And apart from that, it favors more amount of P. gingivalis, which is your periodontal pathogen, which is a key periodontal pathogen. It's a gram-negative anaerobic bacteria, produces endotoxins, and then causes one of the main reasons for periodontal disease. And you see increased amounts of these P. gingivalis when compared to your Aggregatibacter, Actinomycetum comitans bacteria. Now this completes your 8 changes with respect to periodontium. The next topic is smoking and periodontal disease. Now we know that periodontal diseases are multifactorial in etiology, and environmental factors play one of the important role or a risk factor in development of or in causing periodontal diseases. And one of the environmental factor would be smoking and periodontal disease. Now there are lots of research which has been done in order to determine the role of smoking and periodontal disease. Now this smoking, we're just telling smoking. It can be just the smoke form of tobacco or even the smokeless form of tobacco. Now both of them have shown some very drastic effects on the periodontium. Now the types of smoke, as I've already told, you have your smokeless form and you have the smoked form. Now BDs are the most popular form of smoking, tobacco form in India, followed by your cigarettes. Now cigarettes is the second most popular one. Apart from that, you also have your cigars, cheroots, chuttas and others like hookahs and chillum and dumtis and so on. Pipe smoking, yes. Now, to introduce the topic to smoking and periodontal disease, you know smoking has been considered as a major factor for periodontal disease. As I told you, one of the most important environmental risk factor for periodontal diseases would be smoking. This smoking, what is the effect of the smoking on individual periodontal diseases? Let's see what's the influence of smoking on gingivitis, on periodontitis, and what is the influence of smoking on refractory or the recurrent periodontitis. If you can see the next slide, it shows what is the effects of smoking on gingivitis. Now, when you talk about gingivitis, it simply means inflammation of the gingiva. So this is mainly because of plaque-induced gingivitis. Now, the development of gingivitis or the development of inflammation in response to the accumulation of plaque would be gingivitis. And if you compare this development of inflammation in smokers with that of non-smokers, the non-smokers have more clinical signs and symptoms of gingival inflammation, or the inflammatory signs are more pronounced in case of non-smoker, whereas they are masked in case of your smokers. So in smokers, you don't find more signs of inflammation. They are masked. Okay. So your gingival inflammation and your bleeding on probing are totally masked in case of your smokers. What is the effect of smoking on periodontitis? When you see periodontitis, means when the inflammation from the gingiva has further progressed to involve your structures of the periodontium, then you would call it as periodontitis. Now, what is the role of this smoking on periodontitis? The more the number of cigarettes you smoke per day, they have seen that the increased chances or the increased prevalence of periodontal diseases goes hand in hand. Means basically they're directly related. Apart from that, there is an increase in the severity and the prevalence of periodontal destruction in smokers, and there is an increase in the pocket depth and attachment loss and bone loss, followed by an increased rate of destruction, and maybe you can say a little more rapid when compared to the non-smokers. There is an increase in the prevalence of severity of periodontitis. As I told, the disease progresses at a more severe rate in smokers than non-smokers, and they have a high chances of tooth loss at a very at a very early stage after the development of chronic periodontitis. Now, as I told, the second last point is it's even shown on the slide, which says that the increased prevalence of periodontitis with the increased number of cigarettes that are smoked per day. You smoke, the number of cigarettes that you're going to smoke per day would increase the prevalence of periodontitis. Now, the last point, if you are able to stop smoking, or the cessation of smoking can decrease the prevalence of periodontal diseases. What is the effect of periodontal smoking on refractory periodontitis or your recurrent disease? It increases the chances of recurrence or the refractory nature of the disease, and increased need for treatment in smokers is a demand, and then an increased need for adjunctive therapies. Not just a routine periodontal treatment is just not sufficient. Probably you have to incorporate some adjunctive methods of treatment, like increase in the antibiotics to control the periodontal disease in case of smokers. And there is an increased tooth loss in smokers after surgical therapy. Even after surgical therapy, the success of the treatment is not that great. What is the effect of smoking on the periodontal disease? Let's see under the etiology and pathogenesis. If you see under the etiology pathogenesis, let's see what is the effect of smoking on microbiology, let's see the effect of smoking on immunology, and let's see the effect of smoking on physiology. Now, what is the effect on microbiology? Now, it doesn't say that the plaque is going to increase, but whatever they say is that there's no effect on the rate of plaque formation, but there is an effect on the alteration in the microbial flora present in the plaque. Now, you can see increased colonization of bacteria or the periodontopathic bacteria in shallow pockets, whereas in deeper pockets, you find increased levels of the periodontal pathogens. When you see the effect on the immunology, the smoking most of the time causes an altered neutrophil chemotaxis and phagocytosis, and there is an increased oxidative burst. Now, oxidative burst is a mechanism which releases lots of free radicals. Now, these free radicals, every cell in the body releases free radicals, but then your body also produces something called as an antioxidant. So now these antioxidants and the oxidants, that is the free radicals, are balanced to keep the state of health in a normal individual. In a smoker, what happens is this balance is lost and there is an excess production of these free radicals. So there are some damaging effects caused by these free radicals. Either there can be lipid peroxidation, DNA damage, and even one fine day the cell can die. So these are the effects that smoking can cause. It can cause an increase in the oxidative burst, and then increase in the release of these inflammatory mediators, that is your prostaglandin E2 and tumor necrosis factor alpha. Now this tumor necrosis factor alpha and prostaglandin E2, they are inflammatory mediators, meaning they mediate the process of inflammation and they aggravate the process of inflammation, thereby causing more amount of destruction. Now this is increased in GCF. Apart from that, the other effects on the immunology would be increased secretion of these neutrophil collagenases. Now, collagenases are basically proteins that are they are enzymes that are released by these neutrophils and other cells in the body in order to break down your collagen. Now, collagen is one of the important constituent of your periodontium. Your bone has collagen, your cementum has collagen, your gingiva has collagen, and even your periodontal ligament has bundles of principal fibers of collagen. And maybe it's type 1, type 2, type 3, type 4, type 5, or any kind of collagen can be degraded by these collagenases. Now, naturally also your body produces these collagenases, but then they are kept in balance with the anti-collagenases, that is your tissue inhibitors of matrix metalloproteinases. Now these TIMPs, that is tissue inhibitors of matrix proteinases, and your MMPs, that is your collagenases, are always kept in a balance in order to keep the state of health. But in smokers, what happens? The neutrophil releases excess amounts of these collagenases and then leading to excess destruction of your collagen, which is one of the important constituents of your periodontium. So the more amount of destruction, the more amount of attachment loss and bone loss. And then apart from just collagenases, even increased amounts of your elastase enzyme, which breaks down elastin fibers, and are present in your increased concentrations in your gingival clavicular fluid. And apart from that, there is an increased production of prostaglandin E2 even by monocytes in response to the lipopolysaccharides or the periodontopathic bacterial polysaccharides or endotoxins released by the bacteria. What is the effect on physiology? The smoking, as the inflammation is increasing because of the plaque, your smoking will decrease the gingival or the signs of inflammation. You can one is important how it masks is it decreases the gingival blood vessels, therefore leading to a masking effect of bleeding on probing and other signs and symptoms of clinical signs and symptoms of inflammation. Apart from that, it decreases the GCF flow and bleeding on probing also is decreased with the increased rate of inflammation in smokers. There is a decrease in the subgingival temperature and an increased time is needed to recover from local anesthesia when pointing that towards your decreased blood supply. Now that we have finished with the etiology of the effect of smoking on periodontal etiology, periodontal disease etiology, let's see what is the effect of the smoking on treatment of periodontal diseases. Now when you're doing a treatment, how well it responds. Now, how well it responds to non-surgical therapy, how well it responds in case of surgical therapy and on maintenance therapy. The effect of smoking on all these therapies that you do. On the non-surgical therapy in smokers, there is a decreased clinical response in relation to scaling and root planing, decreased reduction in probing depth, and decreased or increased clinical attachment loss, or a decrease in the clinical attachment gain, and there is a negative. Now, all these negative factors can be corrected or they can decrease if the patient is able to quit the habit of smoking and even after maintaining a good oral hygiene. What is the effect of smoking on surgery? Now, you do a surgery, periodontal surgery, and how does smoking affect? How does it affect the periodontal surgery? Right? Now, even they've noticed that smokers who have undergone periodontal surgery do not get much benefit out of the surgical treatment that is performed. There is hardly any gain in attachment. There is decreased pocket depth. There is no decrease in the pocket depth, and then even after the periodontal surgery, there's no response to the treatment that you have done, whether be it regenerative treatment or whether be it just normal surgical therapy. And then there are some conflicting data regarding implant success. How successful are implants in case of smokers is still a conflicting result. What is the effect of smoking on maintenance therapy? Now, if the patient is able to maintain, if you have to actually motivate the patient maybe you have to do an additional motivation for the patient in order to maintain his oral hygiene. If he's at least able to maintain oral hygiene, probably you can put him on some recall visits and then check for his periodontal status. But then, as they have seen these patients, when they've followed these patients, these smokers suffering from periodontal disease, they found an increase in the pocket depth as the follow-ups increased. Okay. It becomes important just not treating the smokers, or just knowing what are the ill effects of smoking on periodontal diseases. You also need to know that, or you have to concentrate even on the part that you have to motivate the patient to quit smoking. And what are the things that you can do as a dentist to help the patient quit this habit of smoking? There's something called as 5 A's. You have to ask the patient, you have to advise the patient, you have to assess the patient, and then you have to assist and then arrange the patient for all the smoking cessation programs. Now first you ask the patient that whether the patient is a smoker, and then you ask the patient whether you have to check whether the patient is willing to quit the habit of smoking. And then second is you advise. You tell him all the ill effects of smoking, what smoking can cause, to be to the periodontium or to the general health of the patient. And then you assess if the patient is got motivated by you. If you need to assess the patient's psychological status of the level of motivation that you have done for the patient. If you feel that the patient is well motivated by you and he is ready to quit the habit of smoking, then you have to assist the patient in doing so. Now, how do you assist the patient? You need to arrange for a session, or you have to refer the patient to for a smoking cessation services. Now, apart from that, you have certain nicotine replacement therapies which are available, which are very helpful, or which have been successful or only helped these patients who are willing to quit the habit of smoking. These nicotine replacement therapies are available in various products. You can have it in the patches form, you have lozenges, you have nasal sprays, or you can have even inhalers. Now, one of such drug, nicotine replacement drug, would be bupropion. Now, this bupropion, usually it is given in a higher doses as an antidepressant, but in lower doses, it can be used as an anti-smoking as a nicotine replacement therapy for smoking cessation programs. Now, this is usually started 1 or 2 weeks much before you can before the patient decides of quitting the habit of smoking, of about 150 milligrams once daily. Then you can gradually increase to about twice daily of 150 milligrams, and then you can continue it for about 7 to 9 weeks. Now you should know the potential side effects of these drugs, and if such side effects do occur, then you have to refer the patient to a medical physician. Now we have learnt about all the effects of smoking on periodontium, and we also discussed what are the why smoking cessation is important. Now, what is the effect of smoking cessation on periodontal tissues? Now, if the patient is willing to quit the habit of smoking, or else he has stopped the habit of smoking, then what are the effects that can occur on the periodontium? The first thing that you should remember, that immediately the patient stops, you have to keep the patient informed that there's going to be more amount of bleeding, because you know that all the clinical signs of inflammation are decreased, or they are masked in case of your smokers. Once the patients become non-smokers, or the patients stop the habit of smoking, so all these signs can again come back. So your bleeding on probing can increase. So you should keep the patient aware of these things. Then what are the benefits? First thing, there is a shift towards your more healthy bacterial flora. Okay, so the flora might become less pathogenic, and then there is a recovery from the gingival microcirculation. You know that we have seen under the effect on physiology that there is a decrease in the gingival vasculature with increased inflammatory response. So when the patient has stopped the smoking, so there's going to be a recovery in this gingival microvasculature, and there is an improvement in the immunoinflammatory status of the patient too. So always you should remember as a dentist that you should see the patient as a whole, and you should not just think of the oral cavity. So you should make sure that you motivate the patient, you give him thorough motivation, and make sure that he stops or quits the habit of smoking. That would conclude your smoking and periodontium. Thank you.